Hello everyone, my name is Dr. Shannick Wick and I am a general adult psychiatrist from Perth. I've also got a special interest in addiction and neuromodulation, especially transcranial magnetic stimulation, which will be the focus of today's discussion. So, a little bit about myself. My main clinic is Neuralia Clinic in Palmyra, where we focus on general psychiatry and the next generation of psychiatric treatments that are a bit harder to access. This includes things like TMS, TDCS, ketamine, and psychedelic-assisted therapy. I'm also the director of Neuralia TMS, which is a specialist TMS service with 7 clinics around WA. Our TMS service also now has no out-of-pocket costs for treatment of depression. I've been formally certified with 3 different courses, and I have no commercial agreement at all with any TMS companies. Alright, so that's me out of the way then. So, what is neuromodulation? Well, I tell my patients that the best way to treat mental health illness is holistically. Now, there's nothing that profound here. It's the biopsychosocial model, which is the foundation of much of modern medicine. But it is really important that we keep focusing on it because, unfortunately, things like mental health is usually multifactorial. There are many different causes for it. It's not usually just one thing, like, say, a pneumonia, which is caused by an infection, just one thing. So let's go through the factors of the holistic model for treating mental health. Firstly, number 1, there are wellness and social factors. This includes things like managing and precipitating factors and stresses, ensuring adequate sleep, nutrition, exercise. All these factors really do matter, and I try to remind my patients regularly of this. Why do they matter, for instance? Well, let's take nutrition. We know that what you eat really does matter. For instance, foods that contain a substance called tryptophan does lead to improved sense of happiness. The reason is tryptophan is found is a precursor to serotonin, the so-called happy hormone, which a lot of antidepressants increase the amount of serotonin between the nerves. Now, they've done interesting research on this. In fact, they've actually given people low tryptophan diets and kind of starved them from that tryptophan, and lo and behold, they became quite depressed. So nutrition does matter. Now, where do you get tryptophan? Well, unfortunately, it's not from McDonald's and whatnot. As you can expect, it's probably from green leafy vegetables. That's where you get tryptophan from. Psychological therapy is the number 2 in the holistic model for treatment of depression. It's important to decide the most appropriate therapy, and a psychiatrist or psychologist can do that for you. Cognitive behavioral therapy is always a great place to start. If you want a quick primer on CBT, what it looks at is the way we approach issues in one's life may be done with somewhat faulty logic. And with CBT, we try to identify what we call these cognitive distortions and make you aware of it so that you respond to events in one's life in a different way, in a way that hopefully does not perpetuate your depressive symptoms. Is medication. So this is all about modulating the amount of chemicals or neurotransmitters in the space between the nerves. So this is what antidepressants does. SSRIs, or selective serotonin reuptake inhibitors, simply block the reuptake of the serotonin in the nerves. So what you'll have is there is more serotonin floating about, waiting to bind to receptors and cause actions than you would without the antidepressant. However, unfortunately, it doesn't always work, which is really where the next stage comes into play. So the other final part of the holistic model is neuromodulation. So instead of modulating the amount of chemicals that are being released by the nerves, well, why not modulate the nerves themselves? And we can actually do that. Now, how that happens is things like transcranial magnetic stimulation is able to either stimulate or inhibit nerves themselves. And when you do that repeatedly, over and over, many times over, the nerves start connecting to one another in a process called neuroplasticity. So if I were to imagine, well, if I was to, say, simplify a very important part of your brain, the prefrontal cortex, the most common target location for TMS treatment, into into two nerves. So imagine, I'll put it here, so my fist is the nerve 1, the nerve head 1, my other fist is the other nerve head 2. My fingers, they're called dendrites. These are basically connectors. And when we want to start off like this, if you're depressed, you might start off like this, and we want to be like that by the end. We want to strengthen the amount of connections and increase the number of connections between the nerves, hopefully providing increased efficiency in transmission of information in what we hope would cause symptomatic improvement. So that's really what neuromodulation is about, modulating the nerves themselves. So the technical definition of neuromodulation is a therapeutic approach that involves direct modulation of the nervous system's activity using electrical, chemical, or other means to regulate its function. It aims to treat a wide range of neurological disorders and conditions by altering nerve activity through the delivery of electrical or pharmaceutical agents directly to target sites in the nervous system. And there are a number of very important sites that we target in neuromodulation. Now, deep brain stimulation is something slightly different. That's used likely in Parkinson's disease and OCD. But we've got spinal cord when you have an implanted electrode that stimulates your spinal nerves, and this is often used in chronic pain syndromes. And the technology is really quite improved and come a long way in the last decade, I'd say, for that. We have vagus nerve stimulation. So this involves the implantation of a device that sends electrical impulses to the vagus nerve, which is a very important cranial nerve. And it plays an important role in regulating various bodily functions. It's used in epilepsy, but also used in depression that is resistant to medication. Not so much in Australia, I might add, but they do a fair bit of it in the United States. And now we, of course, come to transcranial magnetic stimulation, the focus point of today's presentation. This non-invasive technique uses magnetic fields to stimulate specific regions of the brain. And it's been used for a variety of conditions, depression, PTSD, OCD, chronic pain, ADHD. I'll get into more of that shortly. So that's a bit of an overview of neuromodulation. Now, I just wanted to briefly cover TDCS. I mentioned it before, and I wanted to explain what the difference between it and TMS is. So transcranial direct current magnetic stimulation is a non-invasive brain technique that has been used as a potential treatment for depression, but other conditions as well. And it looks a little bit similar to TMS, but it's relatively different, and I'll try to explain that now. Bear with me with this a bit of a weird graph, but what TDCS does is it tries to increase the likelihood that a nerve, say prefrontal cortex nerve, which has an important role in mood regulation, it tries to increase the likelihood that that nerve activates. So if you see this graph on the PowerPoint slide, there is a certain firing threshold. If you give that enough energy, that nerve is going to activate no matter what. There is a baseline level. So this red line, if you can see where my cursor is, it's blue line here, and then when you increase it goes to the red line. That is really kind of that baseline level of energy that the nerve has when it's not being activated. If we are able to get that baseline higher up, closer to that firing threshold, less energy is required to make that nerve fire. And that's what TDCS tries to do. It tries to increase the baseline upwards, so less energy is required to cause that nerve to fire, so it's more likely to fire, and hopefully you're more likely to get some improvement in the symptoms, say depression, if you're targeting the prefrontal cortex. To be honest, it's not as effective as TMS, it really isn't. But the advantage is it can be, we can send, and we do, we send the whole TDCS set to somebody in the country who is far away from a TMS machine. And that can provide some relief, and it could be good in a maintenance situation as well. So that's a little bit about TDCS. And there's a little bit of a graph that explains it. So TMS. Okay, so what is it? So TMS, which the full name is repetitive transcranial magnetic stimulation, involves stimulating nerve cells by using focal magnetic impulses. Now, during a single session, a patient receives thousands of stimulations, and when this occurs, as I mentioned before, nerves start connecting to one another in a process called neuroplasticity. And by the way, the magnetic field actually does do something. If I was to do what we call in the mapping phase, the first appointment, to calibrate this machine, I have to see how much energy is required to cause a nerve in your brain to fire. Now, I can't actually see when around the prefrontal cortex, it's around about here. I can't see when one of those nerves fire, so just for the testing session, I move to the motor strip, really between your ears. And the hand is an easy place to reach, and I'm able to do a pulse, magnetic field pulse, activate that nerve, and I would cause your fingers to twitch involuntarily, a bit like a voodoo doll. And whatever number I get on the machine, that's the minimum amount required to cause your nerve to do that, your hand to do that twitch, is what we input and personalize and customize your protocol for you. So you do get to see it working. TMS is non-invasive, and it's generally quite long-lasting. We're generally talking about years of some people, a smaller minority, may need treatment again before a year, for instance, but most people get long-lasting improvements. It's drug-free, it's safe, and there's actually no long-term side effects that we've seen in about 40 years of research. There are some short-term ones, though, and I'll get to that shortly. So, how does TMS work? So TMS uses an alternating current passed through a metal coil placed over the scalp to generate rapidly alternating magnetic fields. Now, this is able to pass through the skull nearly unimpeded and induce electrical currents that cause the nerves to activate. Sounds a bit scary, but really it is very safe. I do test all these protocols on myself just to see how it responds. I can explain to patients. No, but there are some people who shouldn't be having TMS, and again, I'll get to that shortly. The magnetic field generated by a TMS machine is comparable to that of an older MRI machine, so about 1.5 Tesla, so it's really quite strong, but it only activates over a very small field, so it's very focused to a point. So you don't need to, worry about metal in your pocket, for instance. It's not going to go flying across the room as you would think with an MRI machine. So TMS stimulates regions of the brain that are underactive in patients with depression, anxiety, and chronic pain. So I'll backtrack a little bit and explain that more. When it was Dr. George in about 1995, if I'm not mistaken, he started looking at this mostly. But what we found is patients who have depression and anxiety have similarities when they're put through a functional MRI scan, the one that kind of lights up, or a PET scan, the one that looks at metabolism and uptake of glucose. What we found was that there was decreased activity in the left prefrontal cortex and the right prefrontal cortex, so that's around about here on my forehead. We noticed that there was decreased activity over there. And later on, we found out that we could use TMS to activate those regions by pulsing it repeatedly, so those nerves started connecting to one another, and there was increased activity. And you can see that in PET scans. If you Google it on the internet, PET scan TMS, you'll be able to see that for yourself. I think there's one on our website as well. So the area that we target is, as I mentioned, the prefrontal cortex, the most common location, but it's not the only location that we treat. The specific area is called the dorsolateral prefrontal cortex with respect to depression and anxiety. So during TMS treatment, magnetic fields stimulate neuroactivity in the underactive regions. When this is done tens of thousands of times over a course of about 7 weeks, lasting changes in brain circuitry occur. The exact mechanism of action of TMS is, well, we can never know for sure, but what we strongly suspect is that discrete cortical regions alter pathological activity within the network of grey matter brain regions that are involved in mood regulation and connected to targeted cortical sites. Now, I'll talk a little bit about how we go about explaining TMS to a patient. So that was quite a technical definition. So here's my kind of explanation. So, firstly, when it comes to treating depression, medication focuses on influencing the amount of chemicals or neurotransmitters in the space between the nerves. Of course, we do know it's more complicated than that. There's brain-derived neurotrophic factors, second messenger pathways, but we've got to simplify it to some degree, and that's really kind of how medication mostly works. Now in TMS, instead of again changing the amount of chemicals in between the nerves, we change the nerves themselves and we make them activate. And we are trying to promote neuroplasticity in this process. So now, here we go. So if you wanted to cause neuroplasticity in your hand nerves, for instance, I could use electrical current for that. Very crudely, I could rip out the electrical power cords like a spy movie or whatnot, and I could just kind of keep zapping your hand like you do with the frog leg experiments over and over and over again, thousands of times over, and we would probably promote neuroplasticity. Why? Because that's effectively how habit formation forms. So, if you want to learn the violin, for instance, what do? You pick up the violin and play a song. What if you want to be really good at it? You practice, right? You practice, and practice. What if you want to be genius level, maestro level? Then they say you have to practice it 10,000 times. When you're practicing it, you are basically stimulating the same neural pathways over and over again. And when that happens, those neural connections start connecting to one another. And at that point, you're effectively creating neuroplasticity. And TMS was designed with the same principle in mind. They thought of that, the way habits are formed, and they tried to replicate it using this machine. Now, when you practice something tens of thousands of times, it becomes muscle memory. Your fingers on the fretboard of the violin know exactly where to go. And that is showing you the power of increased neural connections and neuroplasticity. However, there is a problem. I can't do the very crude power chords, zapping your hand thing to the brain. Why? Because if I did, I'd probably just burn your scalp and I wouldn't get anywhere, because the skull is a very poor conductor of electricity. However, in 1985, Professor Barker from Sheffield, who I had the great honor of meeting February last year, he had the idea that magnetic fields can actually pass through the skull. They had MRIs back then. And then he remembered his high school physics when he remembered the father of electricity, Michael Faraday, was his first law of electromagnetic induction. Whenever a conductor is placed in a varying magnetic field, an electromotive force is induced. And that's how we get the nerves firing inside the brain. We don't need a electrical current, we just use an alternating magnetic field, and we induce electromotive force, and we make those nerves activate, which we see in the testing phase of TMS when we get your hands to contract, finger and thumb usually, to calibrate our machines. So, we are all very grateful, us in the TMS and neuromodulation community, for Professor Barker and his colleagues in Sheffield. For one, they credit a wonderful device, but number two, he made the decision not to patent the technology, which is probably why Neurali, for instance, is able to offer it today. It's probably why Medicare is able to cover it. It would be very expensive otherwise. So we very much appreciate Professor Barker, who did a wonderful thing for psychiatry. Now, subsequently, researchers did come up with modalities to deliver multiple pulses in short intervals, and that became what we know as RTMS, repetitive transcranial magnetic stimulation. TMS was then FDA approved in the United States in 2008 for depression, and over the years that came afterwards, other indications became approved. In Australia, it's been around here for about 8-9 years, possibly a little bit longer in research facilities, but it's only been in larger private mental health hospitals for about 5 or 6 years. However, it was in September 2021 where we had the biggest change, when TMS was listed for the first time on Medicare, and that was a real game changer, because for the last 40 years, and the reason why TMS is not used more, it was prohibitively expensive. We're talking about, on average, about $8,000 in October, in August 2021. But a month later, when Medicare came on board, the price dropped a lot more. There was still a bit of a gap. But now, for instance, for depression treatment, Neurali has zero gap. There's no out-of-pocket. So that's been a real game changer, and for that reason, we've had so much more people have access to this treatment. All right. So this is a little bit about what a TMS machine looks like. This is from our clinic. As you can see, you can kind of see there's a coil with my cursor is, and that's attached to a boom arm there. And then that's you can see there's 3 boxes and a computer screen. At the bottom, we've got a power supply. In the middle, we've got a cooling unit, a liquid cooling unit. At the top, we have the pulse waveform modulator, which is able to adjust the pulses to what we want to do. Either we want to inhibit nerves, or more often than not, we want to stimulate and activate the nerves. And this is a bit of a recliner chair. You can sit back, relax, chat with the mental health nurse, or you can watch some Netflix. So it's a pretty chilled out sort of environment. All right. So another picture. Moving on. Now, just a couple of key words I just wanted to cover here. So, sorry, moving a bit back and forth here. Apologise. All right. So, I wanted to cover some key words in TMS that you might hear. You may not, but possibly. There's a high frequency. So high frequency stimulations, things like greater than 10 hertz, they generally cause nerves to activate their excitatory stimulations. Low frequency stimulations, 1 hertz for instance, generally inhibit nerves. So we don't actually know surely why one does it and the other one inhibits and one stimulates, but we definitely know from research that that's what happens. So in contrast, low frequency stimulation in PTSD inhibit cortical activity, and we usually direct that to the right prefrontal cortex, so around about here. Inhibitory stimulation to the right DLPFC, dorsolateral prefrontal cortex, is an alternative treatment used in depression. This can be useful in patients who are at high risk of seizures, for instance, or have got migraines and headaches. In the left prefrontal cortex, we generally use those high frequency stimulations, so 10 hertz and above, and that's probably a bread and butter sort of treatment, left-sided 10 hertz DLPFC treatments for TMS treating depression. There's a couple of other kind of keywords here. We covered most of them, but they're the intensity. So this is just how much energy is required to cause a nerve cell in your brain to fire. That's how we kind of determine what your intensity is going to be, and we test that in the mapping phase. All right. So what can we use TMS for? Well, I've mentioned them already, but major depression really is our bread and butter. We've been doing that for many years. We've got a lot of research behind it, and some pretty decent statistical rates that we'll go into for that. PTSD, we do a lot of that in our West Leaderville clinic, which is a trauma clinic, but we can do it in any of the machines. OCD, so OCD is a real interesting one. We have a whole separate coil for treating obsessive compulsive disorder called the deep TMS coil. It's a whole separate area that we treat. Deep TMS coil just penetrates deeper the magnetic field, and we're able to target specific locations, and we've since moving to that new coil, we've been having really decent results with that. We can treat chronic pain. We can either treat that from centrally, so over the motor cortex. We can treat the prefrontal cortex and modulate one's perception to pain, or we can even get the coil and just place it, wherever it hurts. Really, the 3-minute treatment. We place it, say, on the back of your hand if you've got chronic neuropathic pain. And that's probably the key word when it comes to what TMS can actually work for. You need some kind of neuropathic pain. So, if you hit your thumb with a hammer, acute pain, it's not going to really work with that. It's for chronic pain and neuropathic pain. We can also treat ADHD now, so that's been really exciting in the TMS world. They started using it about 7 months ago in the eastern states. We've been using it for 3 or 4 months, and that's very exciting. That's probably the most exciting thing happening in TMS, I think, right now, that's finally come out after years and years of research. Good. Tinnitus, we use the MRI navigation because unlike the other psychiatry indications, it's quite hard to find the auditory cortex, and it's really not very big. So we use an MRI guidance, and we do have these systems and machines for that. But yes, we can treat tinnitus. And Parkinson's disease, we can certainly treat Parkinson's disease as well. We usually do that in consultation with a neurologist. And there's different targets that we treat. Supplementary motor area is a common target that we use. We also target the motor cortex to try to improve the motor function. But probably most of our patients that we treat at the moment are major depression, PTSD, OCD, and kind of chronic pain and ADHD sort of fill out the rest. So who are the people who really shouldn't be having TMS, or when we have to think harder about it? Well, overall TMS is very safe and non-invasive, but there are some important contraindications to consider. And they really kind of span two categories. One, non-removable ferrous or magnetic material in the head or neck. So think aneurysm clips, cochlear implants, VP shunts, any kind of metal magnetic plates in your head. Things like titanium are usually fine and not ferrous. But if you had jewelry or something, we'd ask you just remove that. If you have epilepsy, if you've got epilepsy and recurrent seizures, then we would worry about TMS possibly triggering a seizure, because especially if we use an activating protocol. But there is some research into TMS being used for epilepsy, so I hope that changes in the future. But for now, epilepsy would be a reason not to do TMS. If you had a one-off seizure and we can have a direct cause is established for that, then we would have to think about it more, and we'll do a little bit more digging into what happened and have more of a conversation regarding that. Side effects. Now, I mentioned in the 40 years there are no consistent long-term side effects that we have discovered, but there are some short-term ones, and here they are here. So headaches. Because with TMS you can get some facial muscle contraction kind of around your head, it may simulate a tension headache feeling. So people may get that tension headache sensation. And taking a bit of Panadol, 1 or 2 tablets, 500 milligram tablets beforehand, certainly can be helpful with that, but certainly talk to your TMS psychiatrist beforehand regarding what's appropriate for you. You may get sensitization of the scalp. It's not common, but it's a relatively easy fix. We move the cord a few millimeters, and that usually does the trick. And if you get any kind of odd sensations around the face, generally moving the cord a few millimeters will sort that out. Now, in terms of the risk of seizure, that's really very low. In fact, the risk of seizure is 1 to 50,000 treatment sessions. And this is coming from, it's kind of the most important paper in TMS safety, Rossi et al. In 2020. It's been refreshed a few times, and it was also seen in another study, similar results in Lerner et al. 2019. So the risk of seizure overall is incredibly low. In fact, it's lower than almost every other antidepressant, which came out in a study about 2 years ago. And generally speaking, as a psychiatrist, I don't often consent or ever consent to patients for seizures if I'm prescribing an antidepressant. So, the risk of seizure is very low with TMS. And we can make it even lower by using a right-sided inhibitory protocol, because what is a seizure? It's just an overactivity of nerves just firing all at once. So if you're inhibiting the nerve, you're kind of doing the opposite there. Now, if you've got bipolar and you're not on a mood stabilizer, then we would worry about the risk of triggering a manic episode. Just like we would worry about the risk of triggering a manic episode if you were given an antidepressant and you were not on a mood stabilizer, such as lithium or sodium valproate or carbamazepine and whatnot. You can people sometimes are on olanzapine and quetiapine as their first line mood stabilizers for mania or bipolar, and that should generally be okay. But we'll again do a bit more digging into that as well. And a systematic review by Z et al. Identified the risk of treatment emergent mania to be 0.84%. So statistically similar to a sham TMS treatment, a risk of 0.73%. So, and these were in patients who had a diagnosis of bipolar. So maybe the risk is not that high, but those patients were also on a mood stabilizer as well. And when I mentioned the statistic, 1 in 50,000 treatment sessions, the risk of seizure, that was assuming that you had no seizure risk factors such as brain lesions or a diagnosis of epilepsy as well, and you were not actively withdrawing from alcohol or benzodiazepines, which also risk seizure due to withdrawals from those substances can risk seizure. So that's a little bit about the side effects of TMS. So does it work? Well, that's a critical question, isn't it? Well, if you look at across all the studies, especially the most recent ones in the last decade, we're looking at about effectiveness rate of about 65%. If you were to look at the studies just in the last 5 years where the technology has improved greatly, those numbers look a bit better as well. But that's probably a good number, 65% to give patients. Which is notably higher than patients who've had antidepressants or multiple antidepressants. We know that from the STAR-D trial, which is the most famous psychiatry trial of all time. So when you have an antidepressant for the first time, you have about a 40% chance of it working. If it doesn't work after 6 to 12 weeks of trying, and you have to try a second one, then that number drops to about 25%. And then again, if you try another one, it drops to 16.8% response rate. So you're comparing. TMS is usually started once you haven't had success to 20 antidepressants. So that's when TMS is given, and if it's getting 65% compared to things like 16.8%, well, there's a pretty big difference there. I would note that approximately 35% of patients who do have respond to TMS may need another course at some point, or a maintenance TMS course. So that's worth noting as well. They're about 1 in 3. So that's a little bit about effectiveness rate. Let's introduce things like TMS in children. Well, what about that? Well, long story short, we can't really do it. We can't do it in Australia. Now, I do know that they do it in the United States, but at the moment, from kind of the law that is here and what medical defence companies are willing to cover, we're not able to do it in children. And the main reason is that we haven't had enough research, at least from the Australian government point of view. We haven't had enough research, and I agree with that opinion as well, mind you. Hopefully that will change in time. Neurale, for instance, is involved in a research project with the University of Western Australia and Perrin Institute, looking at adolescents and TMS. So hopefully we can be part of that. It was really a question of, is the magnetic field, with the difference between, say, a 5-year-old and a 17-year-old, a 16-year-old. That's what we'll try to investigate here. So I suspect we will be treating children in a not too distant future with a little bit more research, especially now that we have a lot more data in Australia because it came with Medicare. Okay, so and I mentioned a few studies there that did it, and they found some different results and whatnot, and we're still just waiting on more research on this subject. What about TMS in older adults? So people, 70 and above. Well, we certainly do TMS with that. In fact, a good part of my population, especially in country sites for whatever reason, are over the age of 70. I've treated a 100-year-old patient before. There was no issues with that case. And there are a number of reasons why we'd probably look towards TMS as opposed to something else, such as medication. One is we want to reduce what we call polypharmacy. People who are older generally are on multiple different medications, all which are likely interacting with each other, causing side effects, drug reactions, and the more that you have, the more complex it gets. So if we're able to take the patient off an antidepressant because TMS is working, which is our main goal, to be honest, we do intend patients to come off antidepressants. Sometimes they stay on it, but we try to get them off it. Then that would be quite useful. Patients who are 70 plus may have liver problems and kidney problems because they have difficulty metabolizing or excreting the medication, so that can be an issue. Low sodium levels and the results of that caused by antidepressants, which are associated with hyponatremia, that can be another problem. Older adults often have high rates of non-response to antidepressants, so worth trying something else. We mentioned ECT, so electroconvulsive therapy, which some people may confuse with TMS, but they're actually polar opposites. So before I answer the part with older adults and ECT, I probably should explain the difference between those two. So electroconvulsive therapy it was discovered about 100 plus years ago, and it was very interesting how they discovered it. So what doctors and scientists noted at the time was patients who had epilepsy, but also had depression, well, every time they had a seizure, they seemed to be in a better mood. So, the doctors and scientists at the time, about 100 plus years ago, had a great idea. What if we caused a seizure in patients who were depressed or had melancholia? They didn't truly understand depression fully at that time. Okay, so how do we cause somebody to have a seizure? Well, the scientists had a great idea. Why don't we give them malaria? So they gave patients malaria. In malaria, you get fevers, constant fevers in a cyclical pattern. And if you've got children who have febrile fever, they may have a febrile seizure. So they did that, and you know what? Patients did improve. Unfortunately, patients also started dying, so it wasn't a very good idea in the end. Another doctor had another great idea. Why don't we just give them insulin? Those who have type 1 or type 2 diabetes will know that if you give yourself too much insulin, your blood sugar levels will drop suddenly. If it drops too low, you'll have a seizure. And once again, it worked pretty well, but patients were dying. And the amazing thing is, now, I can't remember which, but either the person who gave people malaria or the person who gave people insulin, one of the two won a Nobel Peace Prize. So I apologize, I can't remember which one, but I promise you one of the two got a Nobel Peace Prize. Anyway, in the end, a doctor named Celinetti in Italy, he had the idea of using electricity. Why? Because you could control it a lot better than insulin or using febrile seizures from malaria. You could control it on a dial. And he tried it on a poor dog, but dog survived, and they tried it on humans, and it seemed to work. Now, unfortunately, it was a violent affair. They were having a seizure. They were strapped down. They were moving up and down. Their limbs were all contracting at once, and they were getting often fractures from that. And it all really changed. The big difference was anaesthetist coming into the picture, giving the patient muscle relaxant, so their muscles aren't spasming as much, and giving them anesthesia so they don't remember that. So that's where ECT came in. So why would having a seizure help with depression, for instance? Well, to be honest, we don't know. But what we believe is that when you have a seizure, you have all your nerves in the brain are basically firing at once, and you get a massive release of every hormone you can think of, neurotransmitter, serotonin, GABA, glutamate, dopamine, you name it. It all gets released, noradrenaline. Now, when that happens, it appears to be like a reset button on a computer, and you power up, you reboot, and you feel a little bit better. Now, it doesn't last forever. You generally need to have another one, but that's how it works. Now, TMS is completely different to that, by the way. We do not want a seizure. I told you that we would preclude patients, unfortunately, who have epilepsy. We're not looking at a reset button switch. We're not causing a massive dump of neurotransmitters. We are trying to create neuroplasticity, nerves connecting to other nerves, and to have lasting effects. And it's a lot gentler. It feels like a tapping sensation on your head or like a rubber band flick, I've heard. That's the sensation that you feel. In fact, there's often there should be no contact really with the head and the coil. It's really that sensation that one feels when you get that magnetic field changing. So that's a bit of an explanation about ECT and TMS. I had to do that explanation on ABC radio once, and in the lead up to the introduction for me coming in, they actually played a scene from Jack Nicholson's One Flew Over the Cuckoo's Nest, and then introduced me. So, hell of an introduction for a psychiatrist, but I was able to give that same explanation. So coming back, a bit of a tangent, but coming back to this, ECT, one real side effect that ECT has is it can cause memory loss. And in a person who's older, you don't want memory loss. Some patients may already have some signs of dementia, and making it worse with memory loss could be a problem. But ECT certainly has its place, don't get me wrong. If you are severely depressed, if you have catatonia or psychotic depression, if it was me, sign me up to ECT first. But really, the stuff under that, I would be personally looking at TMS for. So to be clear, TMS is not a replacement for ECT. TMS is best for mild to moderate depression, and ECT is really for that severe and catatonic psychotic depression as well. All right. So I mentioned a little bit about what the research says, and effectively, just to cut a long story short, Lang et al., for instance, in 2015 found that it was effective for treating older adults. We certainly have anecdotally found that in our clinic. And he found a decent response rate of nearly 70%, and a remission rate of 37.5%. And I think that reflects the fact that this study was done in 2015, when the machines were a lot better than the machines that were done in 20 years ago. And the machines, we've got the latest machine, those machines are even better than the ones from 2015. It just keeps getting better and better, I reckon, with the machine technology. Worth noting, though, that due to patients having cortical atrophy as they get older, theoretically the risk of seizure is increased. So that's worth noting, but overall it remains low. And they may need a higher intensity potentially for that same reason, in terms of the TMS energy requirements to cause that nerve to activate. Right, so I think we've covered a bit of that already. What I'll do is I'll talk to you a little bit about the, what's a patient journey. We start off getting a referral, generally from GPs or psychiatrists. It can just be normal referral, just a letter, or we've got an online referral form as well. And then I will, we do a nurse will, do initial history and a review with them, and then I will do another one as well. And we would be talking about the full psychiatric history and whatnot, but importantly, we'd be, ruling out contraindications, determining if they're actually suitable for TMS. Is there something better they should be trying first? And if they kind of meet all of that, then we go on to the next stage. And we've got a mapping appointment. This is to determine the location of where we're going to treat. So exactly where is the prefrontal cortex that we're going to treat, and how much magnetic field energy is required to cause a nerve in your brain to activate. Because if your nerve is really not firing, for instance, in the depression protocol, I'm doing nothing for you. So we need to get that one right. And then we have the treatment sessions. There are 35 treatment sessions. So while there is no longer a financial barrier, I would like to think, with depression, because we charge no out-of-pocket, there is a time commitment involved. So ideally, we want to be coming 3 to 5 times a week. For the appointment, we're thinking about, say 20-minute long appointment, 3 to 5 times a week, for 35 sessions. And that's what Medicare will cover as well, by the way. Then we, do a review in the middle as well, make sure you're improving. We'd expect you to be improving around session 15 to 20. And I'm doing a final review with myself to figure out what the plan is from here around session 35 or 30 to 35. And write a letter back to the GP, and I might make some recommendations, or if they did want to start weaning off that antidepressant, what would be the best way to do that? Generally very gradually, I might add, very slowly, it would be the best way to do that. We usually can get people off the antidepressants, but occasionally some may stay on a small dose, usually quite a small dose, because they just can't get off it. But most of the time we can succeed getting people off it. Good. And then we'll just catch up with them in about 4 months' time, or 3 or 4 months' time, to see how they're going as part of a routine follow-up. Good. So, and by the way, with TMS, once you've had that treatment, you can drive home. You can do whatever you like. There's no downtime. You're not under anesthesia. It's pretty comfortable. You can just watch Netflix throughout the treatment, or just chat with our nurses. So you can fit into your day. We try to run before work and after work as well hours. So try to make it convenient for people. Now there is some criteria for treating depression. So you have to be 18 or older. You have to be diagnosed with depression. This is a pretty cruel addition to the Medicare criteria, which we TMS psychiatrists all really hate. But if you've had TMS privately before, I think it was November 2021, you can't get the Medicare rebate. Yeah, I don't see why, and I really hope they remove that, because it really does seem quite unfair. And I hope they remove that. So, oops, I skipped over. And the other one, and probably the most important couple, is they've had some psychological therapy during this phase, and they have failed to improve during this phase from at least 2 different antidepressants. So things like sertraline or venlafaxine, something like that, or agomelatine, valdoxone, for instance, plus SSRI, Lexapro, something like that. And they need to have tried it for at least 3 weeks before they switch to the other one. And we are, by the way, this is what we assess. We ask the patient all these questions, we take their word for it, and determine if they meet the Medicare criteria. This is a little bit of an online referral form over here. It tells us a little bit about how we, you can either use a normal referral form, or you can just use our online website. Just very much about the end of it. So in summary, TMS is a great drug-free treatment for a number of psychiatric conditions. It's now been added to Medicare for depression, reducing the overall cost to patients significantly. And this is really the ideal time to refer a patient for TMS is if they're not responding sufficiently to antidepressants, they cannot tolerate the side effects of antidepressants, or is very keen to be drug-free. The most common ones I seem to get is sexual dysfunction, especially with men, erectile dysfunction from antidepressants, numbness, emotional numbness. These are the common side effects that really bother patients that I find as a psychiatrist, and the ones who do TMS often have that history. Or it just doesn't work, of course, antidepressants don't work. And if they've tried 2 antidepressants, this will usually be covered under Medicare. Mentioned the idea of drug-free, non-invasive, no long-term side effects, but potentially some short-term ones. And the condition it treats is major depression, PTSD, OCD, chronic pain, and tinnitus. And that's about it. So thank you very much for listening. So feel free to reach out at info@neuralia.com.au if you had any questions, or you wanted a little bit extra knowledge about any particular topic. So thank you very much for your time. I think it's a very exciting time to be in the mental health space at the moment in Australia, specifically in Australia. And the reason I say that is I believe we're the only country in the world that has publicly funded, to this scale, TMS. And we are definitely the first country in the world to legalize psychedelic-assisted therapy, which is something else that we're doing here at Neuralia. It's particularly useful for PTSD, I might add. TMS, probably depression, but PTSD, very exciting, the psychedelic space on that. Being able to inhibit the amygdala, which controls your deep emotional memories, and to prime the prefrontal cortex. It's almost like having years of therapy in a very short space of time. That's what it's offering, and we're going to see more research in this field. And so Australia is a place that has it all. So thank you very much, and I hope to see you all at some point. Bye.